Welcome to Conversations with Esther tonight. We are excited to have Daktari. Thank you, Daktari. Thank you, Dr. Maranga, for accepting the invite. Daktari is very easy to deal with, very easy. And I must say this, we met in a different forum and I just said, Daktari, I want you to come. He said, anytime. And I said, Daktari, it's pro bono. He said, I do a lot of pro bono and I want to educate and inform the community. So thank you, Daktari. Allow me to pray, then we can move on further in Jesus' name. We thank you for this session. We pray that you be with us, you lead us and guide us in Jesus' name. Amen. Allow me to share something. Just an intro of Conversations with Esther, and then from there we can move on straight to what Daktari has. I'll just be very brief in the interest of time, and I know we have a lot to learn. So for those that are joining us for the very first time, welcome to Conversations with Esther. We are an impact-driven professional platform that informs you, educates you, and rebuilds your mindsets on matters work, organizational culture, and your holistic wellness. Now, we ignite ethical and authentic leadership, promoting best practice within industries. Now, Conversations with Esther equips the workplace with relevant legal, human resource, and holistic wellness skills through training, motivational talks, end-to-end human resource consultancy support, and mentorship programs. We are guided by three values: integrity, excellence, and impact. And we envision a workplace transformed by professional conversations like what we have tonight, respectable relationships, and intentional leadership. Now, this is what we ask you every time we meet. Which is your 2026 pillar? We promote wellness, holistic wellness around the 7 pillars of wellness. That's your physical wellness, your mental wellness, your financial wellness. And I know what we have tonight touches every one of these pillars. I know Daktari will confirm that. Your social wellness, your spiritual, environmental, and intellectual wellness. Tonight we have Daktari. Your health is your wealth. Your health is your wealth. Now, and it deserves informed attention. Tonight we host a highly qualified obstetrician, gynecologist, and oncologist, Dr. Innocent Maranga, as we dive into the women's reproductive health and cervical cancer awareness. This session will empower you with knowledge on prevention, early detection, and overall reproductive wellness, because awareness is the first step to prevention. So I will stop sharing this and allow me to just go through. I got Daktari's profile. Now, if we go through his profile, we'll do that up to 9 p.m. So Daktari, I'll just pick on a few. Dr. Maranga holds a Doctor of Philosophy PhD degree in Gynaecologic Oncology from the University of Manchester, UK, a master's degree in medicine in obstetrics and gynecology from the University of Nairobi, and a master's degree in public health from the University of Liverpool, UK. Additionally, he holds a postgraduate diploma in STI/HIV and a bachelor's degree in medicine and surgery, both from the University of Nairobi. Others are Fellowship in Gynaecologic Oncology, University of Nairobi, Fellow of College of Obstetricians and Gynecologists, East Africa and Southern Africa, and many others. Daktari is a practicing consultant, obstetrician, gynecologist, and gynecologic oncologist. What, Daktari? In the Kenyatta National Hospital, and an honorary lecturer at the Department of Obstetrics and Gynecology. Now, this profile is huge, Daktari. Allow me to leave it at that. I'm looking at the pages. I think actually it's 19 pages. 19. Karibu sana, Daktari. I want to give you the stage. Karibu sana. You speak to us.
Oh, sorry, I didn't muted. Thank you, Esther, for that very generous introduction. Sorry, I sent you my CV instead of sending you my profile. I'm sorry about that. It's one of those things which you have when you're looking for a job or a promotion. Sorry. Now, thank you for those kind words, and thanks also, Anne. Anne, I can see in the audience. I've known Anne for many years. I didn't know she was going to be here. Anne, how are you? She's probably muted. Thank you.
Very fine. And I had to be here. Thank you.
Asante sana. So without much ado, we are going to talk about cancer of the cervix. When we met with Esther in Samfora, she asked me to come and talk to this forum. And well, my first thought, as we discussed, was we talk about the commonest type of cancer in women, and that is cervical cancers, a disease which I've been treating for over 2 decades. And unfortunately, it tends to be very, very common in our setup and has a very devastating effect, especially if it's not caught earlier. We can proceed to the next slide. So this is what we're going to briefly discuss about. What is cervical cancer? Sometimes for ourselves medics, we tend to use a lot of jargon. I will try as much as possible to avoid such and to oversimplify issues and not to take anything for granted. So we'll talk a lot of basics. Allow me to do that. So we'll talk about what is cervical cancer, what causes cervical cancer, how can it be prevented, how does cervical cancer patient present, how do we diagnose it, is there any treatment, and if there is any treatment, which ones are available, and then we conclude and we get questions and answer session. So the most important for me is actually the last one, which is the question and answer session. My presentation is really just to set platform for us to have a conversation, so that we can hear what questions you have, what concerns you have, and basically have this conversation in these conversations with Esther. So I do work at Kenyatta National Hospital as a gynecologist and also as a gynecologic oncologist. This is a public hospital. It's among the very few public hospitals in this country which offer full treatment to cancer treatment. It does have radiotherapy, it does give chemotherapy, it does surgeries there. The other public hospitals which are able to give cancer treatment are Kenyatta University Hospital and also Moi University Moi Teaching and Referral Hospital. And the other facility which I do also work in and also help in running is called the Gynaecologist Hospital. This is located within Nairobi, inside Sunview Estate, opposite Kenyatta Market. It used to be a university campus a while ago, but it's a level 4 hospital at the moment. Next, we see just a presentation of what we generally do on a daily basis, including today. That's why I got a little bit late trying to organize this. This is surgery at Gynaecologist Hospital, where we are able to do various types of surgery, including cancer surgeries. We also do give chemotherapy there. We give transfusions and other types of treatment. The next one is this is not cancer. This is a fibroid. Some of you may be familiar with that. Common ailment among women, one of the commonest really. And in this case, we had just removed a huge fibroid. Next, we have that's a huge ovarian mass. This unfortunately turned out to be cancer of the ovary, some surgery which we did some couple of months ago in a 56-year-old lady. And the next is part of basically for the benefit of the audience. Those are the insurances which we have at the Gynaecologist Hospital. So you may see one of which you are probably affiliated with, but we do also have SHA, since it's the national insurer. And then now delving into the matter of this one is a leading interchanging with breast cancer. Breast cancer is more commoner. It's commoner in certain circumstances, in certain locations. But overall, if you look at what kills most, it is actually cervical cancer. So it causes more mortality than breast cancer. So what you're seeing there is basically the anatomy of the cervix. And as you can see there, the cervix is really the entry from the vaginal canal into the uterine cavity, to the window there or the door. And it's a very small organ, but it tends to cause a lot of havoc when it is involved with the cancer. And as a general introduction, cancer generally can affect any organ in the body, except hair and nails, as we say. So it can affect any organ, whether it's the breast. In men, we talk of prostate. In both sexes, we talk of colon, lung cancer, esophageal cancer. In women, we have ovarian cancers, uterine, stomach cancer in male and women. So it can affect anybody and any part of the body. In the next slide, we are seeing the various stages of cervical cancer. The first one there shows a cut section of cervix and a normal cervix, for that matter. And the second figure shows an early stage cancer, which we are calling stage 1, stage 1B, and then it continues to stage 2, to the last slide there. And cervical cancer usually can be classified like most cancers from stage 1 to stage 4. And generally, when you hear stage 1, it means it's really a cancer which is confined to the cervix. Stage 2, it has moved a little bit to the surrounding structures of the cervix. Stage 4, it has really gone advanced beyond the pelvis and probably to the rest of the body. So in the next slide, we are looking at what causes cervical cancer. For a long time, it wasn't very clear on what causes cervical cancer, and that was in the 80s, in the 70s, and then in the 80s, it was suspected by Professor Zuhausen. He was a German professor, virologist, and there was a tug of war historically. His thesis proposition was human papillomavirus was the cause. Others felt it was herpes simplex virus, but it was later proven that actually almost 100%. Almost 100% of virus, and they actually received the Nobel Prize for Science the year 2000 and something. I can't remember when that was. I had the privilege of attending one of his lectures while I was in the University of Manchester, now in around 2007 or thereabout. So that is graphically what is the human papillomavirus. Is a DNA virus, which is very, very, very common. So common so that it's actually taken to be the commonest sexually transmitted organism in human beings. Just to give you an example, if you take a cohort of or a population of human beings or couples, by the time they reach 60 years of age, almost 90% of them would have had HPV infection at some point of their sexual lives. Fortunately or unfortunately, but I think it's fortunate, 95% of these would actually eliminate it using via their immunity, and only 5% would actually have persistent human papillomavirus. And it's this persistence of having human papillomavirus on the cervix, which now lead to development of what you call precancer stages. Those are stages which develop before actual cancer develops. And after some years, that can lead to cervical cancer if it is not detected earlier and treated appropriately. So that is human papillomavirus. We are going to see shortly that there has been revolution in terms of prevention of cervical cancer. We do have human papillomavirus vaccine nowadays available, and I hope those among us who have daughters, we've taken them for that vaccine. I incidentally have two daughters. One is turning 17, another one 22. And I did take them to have the HPV vaccine. Actually, a number of women would ask me, is it safe? And I would basically just tell them, if I look at the havoc that human papillomavirus causes vis-a-vis the benefits, I would generally go for it for the human papillomavirus. So even ourselves, we still do qualify to go for HPV vaccine, as much as it is recommended mostly because of government funding for girls between the age of 9 to 15. And in the next slide, apart from human papillomavirus, what are the other risk factors? HPV is central and is sexually transmitted. But of course, the risk factors are really risk factors for getting STIs, which include herpes, syphilis, chlamydia, and the other types of sexually transmitted infections. Having multiple sexual partners is a high risk factor, or having a partner who has multiple sexual partners, or a partner who has cervical cancer, who has been treated with cervical cancer. Of course, smoking is also a high risk here, and low immunity circumstances where the immunity is low, like in HIV/AIDS, or patients who are undergoing chemotherapy for whatever reason, or patients who are undergoing dialysis. or diabetics for that matter, although that's not a very strong one, the one of diabetic, but situations really which lead to a low immunity. Now, in the next slide, we're going to look at how can it be prevented. Prevention of cervical cancer. So prevention is really to prevent acquisition of human papillomavirus, and that is where delayed sexual debut is important, especially in younger people, in girls, in our daughters. When you keep them more in school and delaying the sexual debut, that is preventive, of course. Chastity or abstinence, use of condoms, although it is not 100%, but it does help, the condoms. And regular screening, having regular annual pap smears or having HPV testing. There are other types of screening that we do use. For those who may be familiar, there are others we call via testing, where we look at the cervix and put some reagent there, and from the appearance, we're able to tell if there's any problem there per se. And of course, we've talked already about the HPV vaccine. So in the next slide, we are looking at how does cervical cancer present. Of note is just like most cancers, if not all, very early stages have no symptoms whatsoever. That's why one is usually encouraged to go for screening, not because one has symptoms, but because it's the right thing to do. And it's best to diagnose some of these cancers, and especially cervical cancer that we're talking about, early enough. And very early, it has no symptoms whatsoever. But as it progresses, you may have unusual, abnormal vaginal discharge, may have vaginal bleeding, which may be even after intercourse or having pain during intercourse, having abnormal, heavier or prolonged menstrual cycle or abnormal bleeding, having discomfort during urination, or generally having low abdominal pains, back pains which cannot be explained, constant fatigue, having one leg with unusual pains or swellings, unexplained weight loss, or loss of control of urination. But having said that, some of these symptoms usually come late in the presentation. So something like pain is not an early presentation, it comes late, and therefore one should not wait for such for such presentations. So how do we diagnose? In the next slide, we are looking at how is it diagnosed. Just sorry about that. So how do we diagnose cervical cancer? We've already talked about pap smear, which is really for screening. We've also talked about HPV testing. And once we do pap smear or HPV, and we suspect that we need to do further investigation, then we use a microscope, which we call colposcopy. And at the same time, we do a biopsy. This may be done under anesthesia. And at that time, we do stage the cancer if it is proven to be cancer. The other images like ultrasound, CT scan, MRI, and nowadays we have what we call a PET scan. All these are available and they can be used for looking at the extent of the disease. And the next diagram there shows colposcopy. That is basically a microscope which you use to look at the cervix. And the next one is we are talking about treatment. is there treatment? Yes, there are treatments. And there are three main modalities for treatment of cancer. There is surgery, where we do radical hysterectomy, which basically means removing the whole cervix, removing the whole uterus, and some lymph nodes and the surrounding tissues around the cervix to make sure that the whole cancer is actually removed. And that is mostly for early stage types of cancer. Secondly, we do use radiotherapy, and there are two modalities for radiotherapy. There's external radiation, and there's also internal radiation. For the third modality is chemotherapy. These are situations where we use injections, intravenous injections, to treat the cancer. And there are other newer types, which we call immunotherapy or targeted therapy, which could be injections or could be even tablets. All these can be used either singly or in combination, depending on the stage and the presentation. The next diagram there is really just to illustrate it's basically the surgery. That is what I just described about surgery. And then the next slide is showing about the chemotherapy, which is basically injection. Chemotherapy is quite a misunderstood terminology, but it's basically injections which we use, and the medication targets cancer cells in the body. The third modality, which you've just talked about, is radiotherapy. That's a radiotherapy machine, which was being launched by the fourth president at Kenyatta National Hospital when he came to launch the radiotherapy machine. And in conclusion, cervical cancer is very preventable, almost 100%. Because of the modalities which we've talked about, the vaccine which is available, the early screening, and it usually would give one a lot of time to be detected, because it doesn't develop suddenly. One doesn't get HPV infection today and the next year has cervical cancer. It takes years, sometimes 10 years, sometimes even up to 20 years. But in situations where one has a low immunity, like in HIV/AIDS situation, then that journey or that period becomes shorter. And when it is caught early, it is entirely curable. And even with late presentation, there's still treatment which is available with good outcomes. That's basically a quote from Mandela: "A winner is a dreamer who never gives up." And in oncology and in cancer prevention and treatment, we cannot afford to give up, and all the energies are always there. Thank you. And I hand over to Esther to carry us on through the other session. Those are my contacts there for whoever may be interested. Thank you, and thanks for listening.
Sorry for that. I think I'll put that up again, just in the interest of those that want your contacts. So then we can possibly just stay on that slide. Just a minute. Then that should. There. Yeah, that's Daktari's contact. You can reach out to him. I will open the floor for questions. I know Sandra had something to ask, and the rest of the people feel free to unmute and speak to Daktari. It's an open forum today. Daktari, it's one of those conversations that people almost want to avoid, but they're very necessary. Yes, Sandra, let me give you the floor before the rest.
Thank you, Esther. Thank you, Dr. Maranga. We've been told that cancer screening is supposed to be 5 years. Is it still 5 years or is it shorter now?
Yeah, thank you. Thank you for that question. It's actually not shorter now. It has always been annual. I'll elaborate on that. Previously, we used to say and recommend that a pap smear should be done every year. And then that was when we used to do pap smears only. And we added that during that time that if you've done 3 annual checkups and they're okay, then you can skip a year. You do every 2-3 years after that. And then now came the HPV testing, which never used to be available. And now with this availability, it was like it can allow one to have a more prolonged break in between. So then there came the recommendation that it can be done between, if one does an HPV test and it's negative, then one doesn't have to do rescreening until after 3 to 5 years after that. But then there is also a caveat to that, and that's why it is always good to discuss these issues with your doctor when you go to see them for that screening. There are situations where one would still be recommended to do the testing earlier, and especially if there are other risk factors, like for example, if one has low immunity in cases of HIV infection, those ones are usually recommended to do annual pap smears because the progression tends to be fast, especially when HPV has also been detected. So yes, there is that aspect of more prolonged break, but it has to be guided in terms of, are there any other risk factors? If there isn't, then a longer period can usually be advised. Thank you.
Thank you, Dr.
Okay, proceed. Anyone else? Dr. as we wait for someone else to unmute, I see someone asking, what do you mean by saying that HPV is a DNA virus?
Oh, yeah. As it was really to describe what it is, there are 2 types of viruses, generally speaking. We have what we call DNA virus, and then we have what we call RNA virus. RNA virus are like the COVID virus, HIV virus. Those are RNA, and they're usually much tinier, smaller than DNA virus. So in other words, it's really to describe the nature of the virus itself. It has DNA material. And that DNA material, if one was to engage a little bit further, it's DNA material which it actually injects and incorporates into human DNA. And therefore it starts producing, it takes over the cell's DNA and starts reproducing itself and continues to survive in the cervix or in the cervical cells. Thank you.
JMM, is that clear? Does that explain? Or do you want to unmute? I see JMM had asked, I don't know what's the full name. So Dr. I saw something on the presentation about HPV 6, 11, 16, and 18. What does that mean?
Yeah, good question. When you talk about HPV, human papilloma virus, there's various types. There are various types. There are those ones we call low risk. Low risk are the ones which cause stuff like warts, genital warts. And then we do have the higher risks, which cause now cancer, like cervical cancer. Incidentally, the same HPV can cause penile cancer, although it's not as common as cervical cancer. It can also cause anal cancer. It can also cause throat cancer or oropharyngeal cancer, depending on people's sexual practices. But the commonest and the most fertile of the tissues is usually at the cervix. So when you talk of low risk, those are the types. There are almost more than 100 HPV types which have been described. Not all of them cause cancer. Others are very mild. 6 and 11 are what causes genital warts, type 6 and type 11. They're also included in the HPV vaccination. Then others are 16 and 18. These are the most aggressive of the HPV types. The most aggressive are 16 and 18. And they cause more than 70% of cervical cancer. There are also other subtypes like 33, 45, and several others, which are described as high risk types.
Anyone with a question? Christine, the rest of the people, anyone? We will be uploading this recording on our YouTube channel. I have shared our link for YouTube, that is Conversations with Esther Katiba. So you can you can share that, reshare with your family once we upload tonight. So feel free to subscribe. The link is there. We will also upload this on my LinkedIn account, Esther Katiba. So if that's your platform, but as we go on, I'm seeing we are 31. Anyone with a question, let's feel free to ask Dr. Alice and Charity. I see. Okay, Christine.
Thank you, Esther, and thank you, Dr. My question is, most of the people, once they are diagnosed and they are given the feedback, we've heard that stigma kills very fast than even the disease itself. So I'm asking Dr. what are some of the strategies that these people can, the doctor can use maybe to talk to these people, because they get like, they feel like they will be stigmatized. You get my question?
Yeah, I do get your question.
Yes.
Yeah, thank you. We did talk about chemotherapy being stigmatized. Indeed, having cancer is also stigmatized. Unfortunately, more often than not, it's taken as a death sentence when one is told she or he has a type of cancer. And one way of breaking stigma is really what we are doing tonight, just sharing information and looking at the reality and facts and trying to separate facts from fiction. So what we do from our end, and I'm also privileged to be, we have a society of gynecologic oncologists, and I'm privileged to be their president. So these are things which we do discuss even as a society of gynecologic oncologists on how to reduce stigma, apart from, of course, standardizing treatment for these cancers in this country, and also in conjunction with the Ministry of Health, looking at how to create protocols and standardization of treatment of cancers in the country, so that whoever unfortunately has any type of cancer, gynecological cancers, so to speak, can get the actual relevant treatment in this country unless otherwise. So that is part of reducing stigma, and one of those is really to give the actual information, and we try to discuss the diagnosis with the patient, and also her relatives. We would have like family conferences to allay fears and to provide practical and factual information and guide in terms of subsequent treatment. It's never really one sitting event. It may take several sessions, but every time a patient comes for review, these are some of the things we would discuss. And apart from that, we do have nurses or psychologists who are trained in such, who also help the patient in navigating their treatment. But yes, it is very true that there's a lot of stigma surrounding cervical cancer and cancer in general in this country. But it is a responsibility which yourself, myself, and everybody else, and the media, social media, we have to take up and tackle it and reduce it for the benefit of better outcomes of those who may suffer from cancer. Thank you.
Thank you, Dr. Someone else?
Good evening. Good evening, everyone.
Good evening.
Esther, thank you so much for planning for us to have this conversation. Thank you, Daktari. That was very elaborate. Now, my question is there a type of meals that we need to align ourselves with so that we can reduce the cancer prevalence? And the fibroid also are becoming a common problem to women. What kind of diets should we get used to so that we reduce this prevalence?
Thank you for those questions. There are actually two questions. One is on fibroids. Let me start with the one on fibroids. Fibroids, as you know, these are benign, meaning non-cancerous. They are not cancerous at all, although there's a very small risk, I think of 0.02% of fibroids undergoing a condition we call malignant transformation, and then it becomes cancerous, but that is a rare occasion. Fibroids are very common. They are genetic most of the time. They are race dependent, whereby you find 1 in 4 blacks, that is Africans, tends to have a fibroid. It may not cause any problem, but it is there, 1 in 4. So it is much higher than compared to the Caucasians or other races. And apart from that, it is more common nowadays than it used to occur in previous generations because we are staying in school longer, we are delaying getting children. We space a lot and we get fewer children compared to the previous generation where they had many children and they used to start getting family early and finished late. So in other words, the uterus, the African uterus, one would say, I could give an analogy of if there's no pregnancy growing, then a fibroid is likely to grow. So if your mom had a fibroid or you have a fibroid, your daughter is likely to have it. In terms of diet, there's no proven diet to prevent fibroids. Going back to diet and cancer, a number of times cancer is a lifestyle, not all of it. And incidentally, there are many cancers that we don't know the cause. Cervical cancer, we know the cause definitely, And evidently, as seen, it is also lifestyle related, depending on sexual lifestyle of somebody, whether they're using condoms or not, whether they have had a vaccine or not, whether they're having multiple sexual partners. That is lifestyle. But generally speaking, in terms of preventing or healthy living, one would talk about a diet which has more of antioxidants. So one is usually encouraged to have a diet rich in fresh fruit, variety of fruits, whatever it is. Those are antioxidants. And also, and this is what we encourage even those who are undergoing treatment for cancer. Also, we encourage a lot of, apart from fruits, vegetables, fresh vegetables. And apart from that, we do encourage a lot of fluids, whether it is plain water, whether it is whatever, sweetened water, sour water, uji, tea, and all that kind of stuff. Apart from that, we encourage one to have a balanced diet from whatever extract they are from. Thank you.
Any other question? Thank you, Dr. And someone is asking, is there any relationship between hormonal contraceptives and the risk of cervical cancer?
Thank you for that question about hormonal contraceptives and cervical cancer. Now, yes, there is. It's a mixed bag of pros and cons. If you look at, for example, oral contraceptive pills like the daily pills, for example, they've been associated with a risk for cervical cancer. But then you have to look at who uses the pill. This is probably somebody who is very sexually active. That's why they have to take a pill daily. So that in itself is an exposure. But also it has been proven at a molecular level that those particular hormones, they do like promote HPV it makes it a little bit difficult for the immunity to eliminate the human papillomavirus. So in a way, it's not really the hormones, the contraceptive hormonal medication or pills or method that causes cervical cancer. It is still the human papillomavirus. But then in terms of cervix, it tends to interfere with the elimination of that HPV from the system by the individual's immunity. So that does happen in terms of cervical cancer, but it is also protective. It has been found to be protective. The pill has been found to be protective in other in other cancers of the reproductive system, like some endometrial types and also some ovarian type cancers. So it's a mixed bag of pros and cons in terms of use of hormonal contraceptives. But having said that, there's no strong evidence in terms of increasing risk for cervical cancer. For otherwise, it would not be in the market. It would have been banned by now. Thank you.
Good, thank you. Any other question? Yes, Mudhoni.
Yeah, thank you so much for the informative session and nice to be here, Daktari. Mutanya, I know referred me to you some times back, about 2 years ago, and I'm happy to be here in this session. And my question is,
Thank you.
Yeah, sure. Thank you. And for the younger girls, probably who are around 14, 15, would there be an effect of the HPV vaccine if they are already probably on a treatment or preventive treatment for endometriosis? If they are already like on that, for example, if they are on Vicene, would there be any effect on that? Thank you.
Thanks for those questions and your kind words. Now, there won't be any negative effect if one is on Vicene, whether it is a teenager or an older woman or a girl. If they're on Vicene for the others, this is medication tablet which you usually use for management of endometriosis, and it does not react negatively with the HPV vaccines. So in other words, somebody who is on Vicene can still have HPV vaccination, and it is pretty safe. Thank you.
Yeah, thank you.
Pushpa? Sorry, I'm using the name that's there. Pushpa. Someone, I see a hand up. Are you speaking? Is there someone speaking? Because I can't hear. Hello. Is it? Maybe as they fix their mic. Anyone else who would want to ask a question or give a comment? I see Anne Kagwi. Anne, how are you doing? You want to say something?
Hi. Sorry, I just joined in.
Okay.
So I'm trying to catch up. Thank you.
Okay. Pushpa, I see your mic, you've unmuted.
Can you hear me now?
Your volume is low. Check on your volume.
Hello, can you hear me now?
Yes, very
Oh,
well.
that's good. Thank you. Jambo, habari gani?
Nzuri. Thank you.
Yeah, I'm originally from Kenya, Mombasa, anyway. Okay, so what I wanted to share, I know I joined late, but I would like to share that cervical cancer, it can be related to PFAS. At the moment, there is no strong confirmed evidence that PFAS chemical that is directly causes cancer. But I don't know if you know what PFAS is, or did you want me to explain it to you? It's some studies they use to make non-stick pots and pans, or they use that on the clothing. Sorry, can you hear me?
Yes, we can hear you. And
Oh,
I'm
sorry.
sure
Yes, we
Dr.
can
is
hear you.
listening.
Yeah. Okay, that's good. So some studies has explored possibly link between PFAS exposures and changes in the immune system and hormones that can inconsistently cause a cervical cancer as well. So like losing microwave, using non-stick pots and pans, there are some chemicals on the clothes as well. So where PFAS still matters is slightly affect immune system to infections, including HPV clearance. So cervical cancer is primarily an HPV related disease, I understand, but not a chemical explore cancer. So it can be like we eat all the stuff all the time. It can be linked to something, but nobody knows how we get the cervical cancer.
Daktari, you want to comment?
We learn, we all learn every day, so there's
I know.
always information coming out. So yeah, but what is established for sure is the centrality of human papillomavirus in the causation of cervical cancer. There's no doubt about it. But it doesn't work on its own. It needs enablers
Yeah.
to it. So those enablers could be reduced immunity, as we have said before. That can come from whatever, whether they're chemicals, whether they're contraceptives, whether it is HIV or other situations which reduce the immunity. Those ones enable the human papillomavirus to stay longer in the body without being eliminated, and therefore it starts causing the damage, which over time can lead to cervical cancer. So
Correct.
that's what I would say. But so there are many enablers, some of which we are not aware. Maybe this is one of them which is coming up. Yes, there's still a lot which we don't know. And there's a lot of research going on globally. Thank you.
Thank you very much.
And I see Pushpa said, oh, okay. What are PFSs found where non-stick cookware, waterproof jackets and outdoor gear, fast foods and takeaway packaging, stain-resistant carpets and furniture, firefighting foams, some cosmetics and cleaning products. And going to that, I think, Daktari, on the cosmetics, I know we have very genuine ones and others that we are not sure. Especially as ladies, think we use what we find sometimes and what is affordable. What would be your comment on that? And the fast foods, actually. I think I need you to talk to us on that one.
Yeah, on that, there are many, we call them carcinogens. These are basically toxins in the environment which contribute to causation of cancers. And if when you're talking about fast foods, or mainly fast food, so to speak, these are unprocessed foods, as we know, or they're over-processed foods. What they do contribute is in excess, there's fat, over accumulation of fat. So the body mass index tends to increase. And it has been found that when there is a high fat content in the body or a high BMI, then there's likelihood to be hormonal imbalance because the excess fat tends to store some of those hormones, and especially in women, we talk about excessive estrogens. And this excessive estrogen and excessive fat then leads to what medically we call metabolic syndrome, which is really interference of how the body handles sugar and fat in the body. And that imbalance can lead to various cancers, and more commonly uterine cancer, or what we call endometrial cancer. So, and the fast foods, there's a lot of literature in that, in terms of diabetes, in terms of even hypertension, high blood pressure, and it's all about increased BMI, arthritis, and all that. So it's not healthy. We all do know that. And it has also been shown to increase the risk of cancer also. So there's a lot that we can talk about, but in brief, you are right. That is basically the other aspect of lifestyle that we need to address.
Wow.
Can I just quickly come in? Sorry.
Okay.
Yeah. Just to update you, yesterday I attended about a session. It was face to face. I'm originally from London anyway. And they showed about how to look after our kidneys. right? And obviously all little things were picked up. And the other thing they said, if you look after yourself, you are very active, not sitting around, eating healthy diet, having enough sleep, drinking loads of water, a very good lifestyle, and not stressing out, you should not have that much issue. And then what happens is people who do not do anything, they, like doctor just explained, they can become diabetic, they can have high blood pressure, BMI increases, and when we go to a doctor, they will prescribe medication, and that medication is got chemical itself, so that can cause issue with every individual person with different way. So I might have a, say for throat cancer, right? Somebody will have some other cancer, but not everybody will have the same thing. Do you understand what I'm saying? So it's medication itself has got chemical in it that causes more issues than having a healthy lifestyle. So I think eating healthy food, cutting down on all the chemical and the oils and all that. Basic, the way I see it, that have a food diet like our great grandparents used to eat, because there's so much fast food in the world now. People just want to grab, or they'll order it online and eat that, because nobody knows what's gone in that food. As far as it tastes nice, they'll eat it, they'll order it again. But sometimes it's fine, but not something like every day. Thank you, Esther.
Thank you, Pushpa. Thank you. And I don't know whether anyone else has something to say. Daktari, as yesterday, I just felt the need to begin a WhatsApp group for caregivers. And I know Jane has shared our community. We have a community on WhatsApp. There's a link that has been shared by one of our members, Jane. Yes, we do conversations with Esther Katiba. Our YouTube is also Conversations with Esther Katiba. We are going to upload that this session on our YouTube. I am on LinkedIn, Esther Katiba, and I was talking about the caregiver because, Daktari, I would want you to speak to the caregivers of the people. I know some people may be here who are caregivers, especially for people with cancer. It drains mentally, and most people are not able to take care of themselves. It's important that we get that support. So Jane has shared a WhatsApp link. That's to our groups. We have a wellness groups that look into the 7 pillars of wellness, which is we talked about the physical, mental, financial, intellectual, and all that. We have a group for women. If you go to the community, you'll find one of our groups called Wanadada Tufunguke, or Let's Open Up as Women. We have a swimmers club for women and a lot of other groups. But actually, on the caregivers point, what would you advise caregivers, those who are taking care of cancer patients specifically? I know there are different patients. Our caregiving group handles different of them. That's what our intention is, to have psychologists, to have doctors like you come and advise us when the group forms. But specifically for today, what would you advise the caregivers who have cancer patients with them?
Thank you, Esther. That is quite a very huge area for discussion, but I'll be brief. Most often, you may even find, as you rightly said, the caregivers are more affected than even the patient. There are many times I've seen sons, daughters bringing their mother to the clinic, and they're actually more affected than their own mother. And it's now actually the mother who is comforting them and telling them, I'm going to be fine. Most often, we always try within the circumstances to involve the family, especially if they are supportive and they come with the patient to the hospital. And we encourage the patients to be coming with the closest relative or children, whoever is available for that kind of support. And speaking directly to the caregivers usually helps, even without the index patient, because then it helps when they're in the picture. And a number of us usually prefer talking to the family in black and white, so long as it is really the trusted caregiver and has the privileges of knowing the details of the disease. And it behoves the doctors, oncologists, to communicate also, and for the caregivers to ask about what is really the plan of management, what is the stage of the disease, what is the planned for treatment, and what are the goals of care. Is it palliative? Palliative is a situation whereby treatment is being given to manage the symptoms, but the disease may recur sooner or later. Or is the goal of care curative, meaning that there is possibility of the disease getting under control and resolving? So those are goals which need to be clear, at least to the caregiver. So there's a realistic expectation in terms of the treatment. And that is where now family conferences come in, and it's the caregivers who should also initiate a situation whereby there is family conference with their physician, and also to have psychologists to support them and to get into networks and WhatsApp groups and groups which are support groups for various cancer patients, and even to seek counseling. A number of cancer centers, they do have counselors to handle this. And once it's clear in terms of the goals of care, then at some point it's important to explore issues of end of life care. If it is a terminal case, what is really required. And sometimes it may reach a point whereby the treatment no longer works, or it's giving more side effects than benefits, and then it is just the supportive care which is being given without the chemotherapy or surgery or radiotherapy. So during those days, and it's a conversation which you should start early, even involving the patient, issues to do with a will, if a will needs to be revised or written, property, succession, and such like issues. So it's a broad aspect, but broad topic. But those are some of the aspects which must really be looked at, so that there are no surprises in terms of the outcomes of the care. Thank you.
Wow. Thank you, Dr. Anyone with another question? I know we've kept Dr. and don't know whether he had a patient. I see.
Can I just quickly come in?
Yes, please.
Oh, thank you very much. Okay, so I've just put a message in there. I think what we need to do overall, I know there are people who are going through, it can be really, really hard for them to lose a member of family, can be a mom or dad or the grandparent who they are really relying on, being an elderly in the house, where they seek advice and support them. The way I see it, that we should make a community cancer awareness message to make it aware in the country or in the village or town or wherever, or at the doctor's surgery, or a note, or like a news, not news as in news, but like a message on YouTube to say, look, cancer can hit anybody at any age. So we are preparing our younger generation as well, because cancer is something, it is not detected very early. It's not like cough and cold that you will see it. It can happen overnight. So it's important to make awareness, encourage early detection in our community by sharing information with them and say, look, anybody can have any cancer, but we don't know when will it come. So we need to make aware in the community to say, if that helps. Also, it'd be nice to have it in like a poster at a doctor's hospital or surgery, or if they've got a medical card, have it on something like that as well, if that helps. So I put my video on so you can see what I look like. Oh, my camera's not working again. Oh, sorry, my camera's not working. I've just been on one meeting. It wasn't working, so it's not working. Sorry about that.
Thank you. Thank you. Thank you for that. I've put up Dr.'s contacts once more on the screen.
Mm-hmm.
Think you can see that on the screen so that
we can. Yeah.
Yes, and we have shared our WhatsApp community. I see most of you have joined already. We will be inviting Dr. of course, to speak more to us so that we can support our loved ones. Unless there's any other question, we would possibly want to come to a close. Anyone else with something to say or a question for Dr.?
I have something to say. Sorry, my camera is not working. I would love to see. I would love to come and help you, support you in a way that to mentor those who are going through as well. I like to be an advocate or ambassador to help people who go through this, because this is something we don't have resources on, and we need more people to come forward, especially when, like I explained, that if it's happening at home, for example, those people need mentoring and preparing them for the worst. I know we don't want anybody to go through it, but it can have a very emotional impact on individually at home as well.
Thank you. Thank you very much.
I'm happy to come to Nairobi if you want me to.
Oh, wow. Oh,
are you in Nairobi?
Yes, we are. Yes, we are.
You know, I'm Mombasa born, yeah, by the way. So I might have got a bit of Kenyan accent.
Karibu sana, karibu, and I know
Asante sana. I am born in Mombasa, so.
Okay, good.
So my heart goes out to people who are in my country to help out, regardless what.
Oh, thank you.
I'm happy to reach out and help you anyway.
Thank you. Thank you. We'll have a conversation, and I know we'll loop in Daktari. I see Muthoni. Muthoni is also a psychologist. She's already sending me messages. So good. We encourage you to join our network so that we.
I have.
Yes, and most of the others on the call. I think unless there's something else, Daktari, thank you very much for your time. I know it was short notice, but you had to help. Tells a lot about this. Thank you very much. Asanteni, have a good evening, and let's keep the conversation going.
Could I just, Esther, thank you.
Thank you.
Just to appreciate your audience, and thanks, Esther, and I want to appreciate your audience for their patience. Thanks, everybody. Pushpa, thanks for that encouraging words, and Mudhoni and everybody else who has attended. We really appreciate you, and I'm available, basically, to be joining you when it is necessary. Thank you very much, and have a good night.
Wow, thank you, Daktari. And I know Daktari is supporting a lot of children. I am in a forum with him, and he opens the platform for children, school-going children, for all this conversation in schools and in Kenyatta Hospital. So I hope you picked his number. I work in school. Oh, Pushpa. Okay, that's a good
Yeah, I work,
conversation.
sorry, let me just quickly come in. I do work in school.
Mhm,
I'm a learning support assistant, supporting students with needs.
mhm.
So I've been doing that since 2001.
Oh, great. Great,
So
great.
education is my passion.
Thank you. I can say that for Daktari as well, because I know I'm in a school forum with him
Are
somewhere.
you? Oh, you can add me on there as well. I am now I have established, I've been here since 86 anyway. I know Mombasa is my birthplace, but I would like to come and support students there
Thank you. We'll have a side
to teach
conversation.
them at least English and maths
Oh, beautiful.
and handwriting,
Oh, good.
speech and
Good.
language, phonic sounds, whatever.
Thank you. Thank you. So, yes. So thank you. Allow me to end this session. Daktari, thank you. Thank you. Thank you.
Thank you
May the
very
Lord
much for
bless you.
everyone.
Thank you. May the Lord bless you. Have a good night. God bless you.
Yeah, and my messages. We can't message on the WhatsApp, can we?
Yes, we can. We can. I'll reach out to you. I will.
Yeah, I've just my name is Pam on there, so you can reach out
Yes,
to me.
yes.
Thank
Yes.
you very much,
Thank you too.
Esther. Nice
Thank
meeting you. Have a lovely evening. Must be late at night there.
Yes, it's 8:30.
10 o'clock? 10:30. Yeah,
No,
yeah,
no,
yeah, yeah, yeah.
8:30.
Oh,
8:30.
8:30. Oh, it's 6:30
Yes.
here anyway.
Thank you. Thank you, everyone. Good night. God bless
Thank you.
you.
Good night. God